Hello, everyone, and a very warm welcome to this panel, which is really looking at and encouraging us all to get very serious about migration as a determinant of health if we are to realize the overall goals and objectives of Sustainable Development Goals and specifically universal access to health. So we have an exciting line of speakers for this session. And I'm going to ask the moderator to move to the next slide. Right, so just a few tips from me. Before I share that, let me just very quickly introduce myself. I'm Anuj Kapila-Shrami, and I'll be the chair for this session. There are some steps which many of you would already be familiar with on using the platform since you have been attending some of these sessions. But the most important thing is to be mindful of the chat box for the live Q&A session. As part of this session, we have structured some lightning talks, which are no more than 10 minutes by each of the speakers. And then an area, and then some time for Q&A. So do submit your questions to individual speakers, or if they are more generic, in that chat box. Also some ground rules. Please use the following hashtags for the conference and migration UHC for this particular session. You can also tweet any questions that you would like to be answered. But the safest way to get those questions picked up in this session for discussion is to also leave in the chat box. Following the lightning talks and provocative talks by the panel that we have today, can you go back to the previous slide? No, the slide before. Yes. So following that, we will have a firebolt round, and that will be picking questions from questions that you have left on the chat box, but also some more directed questions for the panelists based on their talks, where we would be then looking at specific responses to proposals in those specific contexts and countries. Next slide, please. Next. Right. So just very briefly, I'm Anuj Kapila-Shrami, and I'm a professor in global health policy and health equity in the University of Essex, in the School of Health and Social Care. And my work has been predominantly in the area of health inequalities and looking at social and structural determinants of health. So looking at the context of migration, transit, as well as destination, and also both in the northern and southern context. So some of my migration research has been in the context of the UK, and the rest has been in the context of South Asia. I'm also chairing the Migration Health UK South Asia Network, which I'll share a link to for those of you who may be interested to join. And in today's session, what I'm going to do, if you can move to the next slide, please. Okay, now go back to that slide. Thanks. What I'm going to do in the next 8 to 10 minutes is just lay the backdrop to this session and why we are focusing on bringing the migration and health policy together and looking at migration as a determinant of health. And in laying the ground for this particular session, I want to specifically identify the strengths and limitations of some of the global commitments, specifically the Global Action Plan that was launched in the 72nd World Health Assembly, and highlight some of the key gaps in translating key gaps and challenges in translating those proposals for migrant-sensitive and responsive universal health coverage plans. And in the session, the overall seminar is really aimed at both understanding some of those health system challenges from specific country contexts, and we are drawing on South Asian and Southeast Asian country contexts, challenges, the health system challenges that are faced by migrants and refugees. Also looking at how other aspects of social inequalities like gender interface with these experiences of health among a very heterogeneous body of migrants. And I go back to the point that Kalitha Wickramadge was alluding to in the plenary earlier on, that there is often a tendency to conflate these differences in this highly heterogeneous group of migrants and refugees. What we will be focusing on is very different contexts and emphasizing on the specific migrant group and category that we are looking at in our in the talks that would follow. A second objective for the session is also to share some of the policy development experiences and learnings in select countries of Pakistan as well as Philippines in attempts to design responsive migrant health policies and UHC country plans. So now coming back to looking at the GAP proposals, I want to, in this introductory talk, really outline 3 key points. First is that we are witnessing a favorable global policy context, and we're at a time where several global commitments have laid emphasis on the need to address migrant and refugee health. Now, most prominent of these, apart from the Global Compact, is the Global Action Plan for Promotion of Health of Refugees and Migrants. And these have come at a fairly opportune time when the nations have been gearing towards achievement of sustainable development goals and specifically universal health coverage, and looking at investing in health and aligned interests, priorities, and resources. The leave no one behind priority and principle around, which is quite central to the SDGs, also adds a certain impetus to include the voices of those with greatest needs. Yet we know that universal health remains a distant aspirational goal, and particularly voices of those with the greatest need and those who are left behind continue to remain excluded from the evidence base that is currently informing the priority setting, decision-making around priority benefit packages in most universal health coverage plans. So when we are looking at a population which is fairly invisible in these priority setting and policy processes, and are only visibilized in emergency settings such as the pandemic, where when migrants were seen out on the streets, making long distance journeys by foot or crossing the river and crossing the channels in South Asia, it was quite evident that this is a particular group living in extremely precarious contexts and circumstances, and almost invisible in the policy provisions that were initially rolled out, specifically these very overnight and last minute decisions around lockdown in countries in South Asia, for instance, really led migrants and particularly the internal migrants and migrant laborers stranded in cities and unable to go back or return to their villages. And almost at the brink of impoverishment and experiencing violence, experiencing blame, among other violations. So within that context, what I wanted to highlight that the GAP commitment does offer some promising approaches. Does offer a small policy window to push the universal health coverage agenda, to push the migrants' health agenda within the universal health coverage plans. But in the session, we'll give a closer examination to what those challenges are, and also what are countries in the Southern Asia are doing about the particular issue. My second point relates to the key strengths that we see in the GAP commitment. First and foremost, it does acknowledge the heterogeneity of migrant populations. It goes beyond the focus on international migrants and the undocumented migrants to really highlight this group of internal migrants which predominate in the southern contexts that we are talking about, especially in India and Pakistan, and contributing to substantial percentage of GDP, contributing to almost 70 to 80% of the informal economy sector. The other laudable thing about the Global Action Plan was its attention to social determinants as tackling migrant health. And it acknowledges that the social determinants that migrant health cannot be tackled by solely focusing on extending coverage of health services in countries. So it was laudable that GAP identified the need to not only address language and cultural barriers, but also obstacles that arise from occupation, blockade of territories, high costs, discrimination, administrative hurdles, social isolation, the inability to affiliate the local health financing schemes, adverse living conditions, and a lack of information about health entitlements and a lack of recognition of these professional qualifications. So GAP is quite prominent in acknowledging and highlighting these broader social structural barriers that migrants and refugees face in their migratory journeys and thereafter. Now, while tackling the social determinants of health is really crucial for achieving all priorities that have been set out in the Global Action Plan, we also recognize that addressing these is one of the most challenging tasks, given that they often occur outside the health sector. And often UHC plans and the priority setting around benefit packages too narrowly focus on specific health services. Now, for example, the challenge and achievement of around social determinants is ensuring healthy lives and promoting well-being, which is contingent on alleviation of poverty and malnutrition, appropriate housing, and many more aspects that are brought out by various social policies, including employment guarantee and education policies. So really what we're looking at is tackling these broader social determinants and also an intersectoral approach to tackling migrant health. So this does offer an opportunity for the WHO to leverage in its health in all policies framework, encouraging the member states to consider the gendered implications of any policies on the health of migrants and refugees, as well as ensure that their specific needs are adequately incorporated in all social policies. For example, there must be a greater alignment of relevant socio-economic and labor policies related to minimum wage, social protection, labor laws. And these challenges have really come to the forefront in the context of the COVID pandemic, which the speakers will illuminate in more detail. So while there are particular strengths in the analysis of migrants' health not simply being an outcome of the services that they're not able to seek, there are significant gaps and challenges within the gap, as well as more generally in the road to achieving universal health coverage. First and foremost, the gap is relatively silent on the political and economic challenges that we are facing today. The discrepancy between the policy rhetoric and global reality is glaring. We have seen the media coverage of deaths of migrant children, separation of children from parents, detention in appalling conditions, and direct targeting of migrant detention centers. Also indefinite detention in overcrowded conditions without drinking water or sanitation. An important aspect for addressing effective migration health policies is therefore international coordination, and more specifically bilateral and regional coordination. But what we are seeing today are increasingly repressive political regimes, anti-immigrant sentiment, and also broader actions that are further invisibilizing communities. There are countries, especially in the South Asian region, who are in conflict with with the neighboring countries. So how do we ensure that we are able to put in place effective policies around to tackle migrant health, which are offering continuity of care regardless of the destination or origin settings. So there are important questions to be asked here, which the session will be attempting to reflect on. Which migrants are covered in our UHC plans, to the extent to which our priority setting and planning processes are really incorporating voices of those who are most affected. And also which member states are making progress in this ambitious endeavor that we have in front of us. So addressing these gaps, this session will aim really at sharing empirical insights and also regional policy perspectives on making health systems more responsive to migrants' health. I'm particularly thrilled because we have a mix of sectors and epistemic communities represented here today, policy, academic and research, as well as practitioner and civil society. So with that context setting, I want to invite the first speaker from Pakistan, Dr. Rumi Aziz. Now, Rumi is a public health professional from Pakistan, works with the Pathways to Impact, and she has extensive experience of working on provincial and national policy design exercises with policymakers and parliamentarians. And today she'll be sharing the status of universal health coverage and health systems in Pakistan, particularly focusing on access of migrant populations, the challenges, and the historical oblivion of researchers and policymakers towards migrant health as a priority agenda. Over to Rumi. Thank you.
Thank you, Anuj. I'll just take a minute to share my screen and then we can take it up from there. Okay, so I'm glad that Anuj has opened it on that point. Thank you very much and a very warm welcome to all of you in this session. And picking up on the powerful documentary that was shown in the plenary earlier in the introduction to the mobility and the aspect of choice of whether people would want to live in struggle-stricken areas and what exactly is it that they want when we talk about addressing migrants, or what exactly is the objective of the entire entire argument that GAP is making in terms of development of investment packages for universal health coverage, and then what is the context in Pakistan really, because we it really varies from country to country. So I'm going to talk a bit about how we have been historically looking at migrants, what is the status of health systems and the access to it, as Anuj just said, and then what is our stance going to be at the end of the day? Do we want to choose exceptionalism because we do not want to hurt them, but we do not want to be blind as well? We are aware of the fact that mobility is the new norm, but how do we address it? How are we really defining migrants? Because that's really deciding our overall approach towards the policy design and the program. And then what kind of evidence do we have in place that is supporting or refuting our arguments for this, right? So I'll just go to the next slide. Yeah, so who is a migrant in Pakistan? When you're trying to visualize the invisible, what does this mean in terms of what is available locally with us and what kind of content is there, what kind of lingo is spoken in the literary circles, in the government circles, when they are talking about making policies and doing research and things like that. So this is, I mean, I really, really like this image because this shows us the extent of where the region has been moving to. And more than 6% of the global migrants hail from Pakistan. That's IOM's data for 2019. And it is this country is hosting the second largest number of refugees worldwide. And until the Syrian war, Pakistan was hosting the largest refugee population in the worldwide. So of the 5 million total Afghan refugees who have lived in Pakistan since 2001, 60% of those refugees were born in Pakistan after their parents and after their families migrated to Pakistan following the Soviet-Afghan War in 1979. So it's been 40 years now. So, and that's the extent of this, of their stay over here in the country. So what do we know about migrants' health? When we were doing the scoping review last year, following a series of workshops on migration health and with the fellow speakers in this session, we were trying to gauge how are we trying to address health system structure? How are we looking at migrants? Are we looking at it from the perspective of health rights or human rights? Because when you're talking about migration as a determinant of health, we'll see as in the next slides also as well, how it's not just about health access, but also access to employment, which is eventually determining access to any kind of facility, any kind of structure that a migrant would have in any country that they are. And then at the end of the day, what are they really looking for? So, and just as some context, so in March 2019, the federal government of Pakistan launched a comprehensive health and social protection program, which is called ESSAS. And two of its components were universal health coverage and protection against catastrophic health expenditures through provision of an insurance card and a social security card. And that launch happened before COVID-19, and it happened alongside another change that was happening in the government, which was to strengthen the systems to address the needs of the 1.3 million registered Afghan refugees and some almost a million unregistered Afghan refugees who are not claiming the refugee status. So I'll just go here. When we're also trying to clarify the concepts of what a migrant really means over here and how the access is being defined in Pakistan. And although there have been state representative commitments of ensuring healthcare provision to Afghan refugees, including provision of identification cards and granting of citizenship, the things have been a bit complex, primarily because there has been no pushing force or no real requirement of following through those systems, because again, the systems in Pakistan, for example, education, for example, health, they do not require at the end of the day a national identification system, a national ID number to cater to anyone and everyone, as we'll just talk about. Sorry. So the health system in Pakistan, the health system in Pakistan, it's primarily divided into public and private sector, and some institutions offered by the armed forces. While the private sector is expensive, the public sector is free for all. Both of them do not require a national identity to address to the healthcare needs of anyone who is walking in through the doors, which means that a refugee who is residing in the country would not face systems different from anyone who is a citizen of the country. Further to that, the fact that there is a very similar language and ethnic and cultural practices of Afghan refugees mean that they do not stand out, which means that which saves them from any kind of taboo that would otherwise be associated with them if there was to be some. And then there are health camps, placed in those locations. But before that, we want to also see if I'm specifically referring to this type of migration and this type of content. Pakistan's not new to the terms migrant, but this is not how we have usually or regularly referred to international migrants or national migrants. We have had a long history, so beginning with the 1947 separation of the borders and post-independence, then within Pakistan because of earthquakes, a lot of movement across the provinces, a lot of movement because of choices of employment. So then we were trying to decipher what would be the best way to decide how or what a migrant is in Pakistan. So any person who's moving or has moved across the border, international or national, but within Pakistan, migrant is not a term that's unknown, but it's being used in a different context. We are covering migrants in our demographic and health surveys, in our other studies, but those are the migrants who are out of choice, people who are moving inside the country, across the provinces, maybe getting married, moving because of jobs, moving outside the country, but these are out of choices, as opposed to migrants who are out of necessity. So refugees or internationally displaced persons, which in this case are the Afghan refugees, or the internally displaced persons, because there has been quite a massive movement of population from the northern and the northwestern border of the country towards the center, while the army was doing a lot of, were doing their operations, anti-terrorist operations. So we have that context. And whenever there is any discussion on migration, it is usually talking about people who have been moving out of choice. And those are the numbers that are being covered in the demographic health survey on the basis of their origin, the area, the district or the province of origin, and places where they are working now. As opposed to that, the refugees or internationally displaced persons are not a part of any survey or study. The ESAS, the social protection program that I was referring to earlier, is one that is looking at them, at their needs. So that makes it very difficult when we try to, the reason why I'm giving all this context is because knowing what a migrant entails or how we are defining it, then eventually decides the kind of evidence that is in place when we are trying to look for them, and then the kind of policies that are going to be in place. So if we look at the evidence that we have there, when we look at the evidence we have, literature that we have, more than 50% of the literature, any literature, is on Afghan refugees, with about 20% on migrant populations which have settled in Sindh post 1947, and very little on crisis setting itself. So it's very tricky because then we have to specifically look at programs designed for Afghan refugees, and then those programs become programs for Afghan refugees as opposed to programs for any migrant crisis, really. And when we look at their challenges are emerging more due to the status of their poverty, the fact that they do not have houses over here or proper employment over here, and they came in really bad shape. That has really decided the course of their lives over the next decades, as opposed to their being not from this country or being from a country alien to the one that they are right now. So when we look at them from a general lens, there is a higher burden on women because of the practices there. And again, that's not because of the fact that they are migrant, but because of their own culture. And that is a culture that we also share with quite a few tribes, even within Pakistan. So when we talk about their general lack of access to health services, again, it is not because the system itself has some bias within it when they are trying to serve their needs, but because the system is already strained and under-resourced. It's already working at a suboptimal level, catering to the need of the extremely large population. And the fact that they are not really defined as migrant, and our registration systems do not ask them to be identifying their identities as an Afghan or as a migrant and as a non-Pakistani so far. So with the health insurance program that's in place now and the private sector coming into it, that's not tricky really. I mean, they have tried to manage it by providing a substitute, a national identification. So that is one place where they will be registering themselves. But otherwise, it has been we have not faced that kind of a bias within the system, which has been observed in other countries. So it's really interesting how this region is showing so much diversity and such a different context. And then there are challenges with their physical and mental and social health, and a lot of health problems. For example, malaria, because of the way their living is and the way their living settlements are, because of access to water and wash facilities, the high prevalence of dental caries and periodontal infections. So again, it is, and not that this is not because of their migrant status, but because migration, when we talk about it as a social determinant, it really is determining their social standing in the society today. Because they do not have money, because they are living in the places that they are living in, they are at a disadvantage, do not have access to proper sewerage, for example, or water facilities, for example, or healthcare because of distances, because of poor infrastructure, which eventually is determining their health, which is why it is important that this does get mainstreamed into the health policy design and structure and how we want it to, move ahead. When we are designing and when we started looking at the migration health related policy and human rights programs within the country and looking at the evidence, we saw that yes, there are programs on gender and women and awareness of availability and access to maternal and neonatal health services. And yes, there are problems related to that, but that was again because of the fact that the system, and Pakistan is one of the few countries which have a critical deficit of human resource, and there is a lot of drain outside the country, and then there is limited production as opposed to the population which is increasing at the size that it is increasing. So that is one of the challenges that we face within the migrants Pakistan, and which is a problem, a barrier for us in achieving universal health coverage, even within the population that's from Pakistan. And then there is state preparedness. I'm not commenting on COVID-19 and what ensued, because that's something that Dr. Shabnam later in the session would be talking about. But the fact that the preparedness policies in general are not covering, until or unless there is a disaster, usually do not cover the extent of anything and everything. Like Cole also spoke in the plenary earlier today of the, I don't know, 23 or 33 countries that they reviewed. There were just 3 who had included migrants coverage in one way or the other in their preparedness plans. So these are the kind of gaps and deficits that we see when we look at the universal health coverage plans within the country. Right now at P2 Impact, we are also working with UNICEF and with World Bank in Pakistan, with the government of Pakistan, to finalize the universal health coverage benefits package. So, sorry. So when we are looking at that, we are also trying to see how we are going to identify or highlight what should be the next priority in terms of migrants. But when we are talking about it, we're also trying to be very careful and wary about, sorry, it's not moving. We're also trying to be very careful about the way we are going to phrase it. We do not want them to be considered as a threat to the local population. We do not want them to be exceptionalized by saying that we need a separate policy for the migrants, when clearly so far they have not faced the biases in the system. And yes, they need to be raised, their living status need to be raised from where they stand today. But is this also a success example of what we are seeing in Pakistan? We are not singling them out. Do we need more evidence around this? So the note where I would want to close our session is that we should not be adamant on one size fits all policy. We need to see the context within each country, and to see that what kind of evidence do we need when we are defining all of that, and then ensure that our systems are not exposing the vulnerabilities of people who are already living in not so much ideal situation, and take it from there. I think I've slightly exceeded over my time, but thank you so much for your patience. Then we'll be taking questions in the Q&A. That's it for my end. Over to you, Anuj.
Thank you, Rumi. That was an excellent snapshot of an overview of the current situation in Pakistan with regards to health systems. And I think the points that you raised with regards to goes back to how defining priorities also goes back to how we define identities and how we're defining the migrant groups is really relevant. So with that, I want to take the audience to a different context and country where the speaker, Dr. Divya Ravindran, would be speaking about health of migrants and children in informal work sites in India. So Dr. Ravindranath works with the Indian Institute for Human Settlements as a postdoctoral fellow there, and her research focus has really been at the intersection of migration, informal labor, and maternal and child health. And in her research, she's been adopting some very innovative methodologies to researching this very precariat migrant group. Over to you, Divya.
Thanks, Anuj. I'm going to share my screen. Okay, so I'm going to talk about informal workers migrant informal workers who live and work at different work sites in the country. I'll start with a very brief background just to give you a sense of the scale and what is the scale both of the problem and the numbers of people that we are talking about, especially children who often don't feature in our conversations on migrant workers. And then I'll quickly move to talking to you about a few challenges that we've witnessed while working with different communities in India, and also reflect a little bit about what are some of the ways in which we could probably address some of these issues. Just to get you started on, what I'm talking about, the scale, there are about 100 million migrants that undertake internal migration within the country. So it's probably the size of many countries smaller countries put together. A large proportion of these migrants are engaged in informal work in urban centers, and this is both informal work in formal sectors as well informal work in the informal economy. So it's a very diverse group of people who work in manufacturing, construction, domestic work, among many other kinds of work that can be undertaken in an urban center. Very often we think of migration as something that intersects with employment based on other forms of intersection. So it's, we have to think about gender, caste, religion, region, because all of these also determine which sectors people go to and what kind of work they undertake. And that is absolutely critical for us to understand, because when we start talking about any solution to migrant health, we also need to know what are the kinds of places they are working with, because that's where the risks are. And I think one of the things that I wanted to quickly outline here is that very often when we talk about migrants or informal work, we tend to put them in a very broad categorization. But if there's one thing that we've learned through the process, through the last few months, through the pandemic, it is that people undertake various kinds of informal work and various types of migration. And we need to be aware of both of these to be able to come up with solutions to addressing health concerns among migrant communities. Migration patterns are often circular among these group of people. So it could be seasonal, it could be temporary, it could be short term. So there is always mobility between the city and the village. Now, in some cases like that of construction workers, there is also mobility within the city because they're moving from one site to another. So there is constant movement that occurs over a period of time. Workers are hired through a very complex network of contractors and subcontractors. And this is also very critical for us to understand health implications, because a lot of our questions around how do we reach workers, the answers actually lie here. And I think the migration literature has talked about it quite nicely, very in depth. But somehow we haven't been able to talk about it equally in the literature in health. So that gap continues to remain. As I said before, there are various types of migration. So there are single male workers, there is family-based migration, which includes children. More recently, there are single female workers, especially for domestic work. So there is considerable diversity, and alongside with that, there is considerable diversity in the kinds of health risks the workers face as well. Women are generally at the bottom of the hierarchy, both in terms of wages and nature of work. And this is, of course, well talked about in the literature, so I won't focus on that. But as I said, this is important for us to know because health outcomes are strongly related to this. A quick note about children. The way we understand migration and the way we talk about the economic reasons of migration, we rarely account for children in this data. And in many parts of the country, especially the tribal belt of the country, a lot of children migrate with their families, and it's hardly ever spoken about. But these are children who are living at the work site, who are living at the labor camps along with their parents, and experience the same health outcomes that are exposed to the same informal work circumstances as their parents, and has the environment of their parents, the work environment has a direct implication for the children as well. There isn't a great, official source that I can cite, but based on various kinds of estimates that not-for-profit organizations and other external bodies have made, the figure is somewhere between 10 to 15 million migrant children. Just to get back to the core topic for today, which is about challenges for migrant health. Of course, there's already, a lot of researchers have pointed out that access to healthcare, one of the challenges for migrants is that there is no continuity in care. Now, as we heard in the plenary, and that also, as it's been talked about often, a lot of migrants suffer from something, for example, like the tuberculosis, which is a sort of caused by the kind of work that they do. Right? It's also easily it's impossible to tackle unless there's continuity in care. The same goes for reproductive health, where women, especially during antenatal care and postpartum care, yet continuity in care is one of the biggest challenges for migrant workers because they're constantly in between places. We've witnessed this in in great detail we've documented this in great detail in some of the work that we've done at construction sites. The other big problem that we have is absence of records, especially vaccination records, maternal and child health records, TB again, for example. And so very often continuity of care becomes really difficult. Negative experiences in healthcare facilities. So migrants often find it difficult to, go to a healthcare facility, especially if the work is happening in peri-urban areas where there isn't great public health systems, or they're under, pressure from the contractors to continue to work and not take a break. This holds true for both, the mother's health as well as the child health, because if the parents are unable to take a break from work, it is impossible for them to take the child to the nearest hospital. As a result of this, there is very high out-of-pocket expenditure as well, because workers tend to go to healthcare centers that are closest to their work site, and this may more often than not be a private healthcare sector. Also about perceived health needs, during the last research project that I was involved in, a lot of mothers said, antenatal care was not required because it wasn't an quote unquote illness. And so the reproductive health or mother's health was always considered to be the least important, whereas child health was considered to be the most important in the priority for the family. The other big problem, and this, we need to think about when we talk about solutions for migrants, is that workers are generally scattered across the city. They're located in different parts of the city, doing different kinds of work, and hence also reaching out to them through a very systematic public health system is very difficult. And this has to be kept in mind when we think about solutions. Government programs and social protection is the other thing that we have to focus on. There is a huge problem because a lot of these workers are not registered at the workplace, and domicile status is considered to be absolutely critical to use to access certain kinds of services. The other big problem is that though we have right now informal workers barely have any social protection, but among the few, there is one that is maternity benefits program. Even that has a lot of conditionalities that workers find impossible to fulfill over a period of time because of the nature of their work. Just to think about what a migrant responsive care system would look like. For me, the most important thing would be to think about healthcare as beyond occupational health, but that also raises several challenges, because how do you study it? Methodologically, doing any kind of work with migrants is really challenging, especially when they live in very highly guarded spaces that are, highly scrutinized by contractors, security, and the rest. So it's very difficult to reach them. And it's also very difficult to think about their health beyond occupational health. Then that also brings us to the question on who is responsible for migrant health. Is it the state? Is it the employer? Or is it the migrant herself or himself? And that's another challenge that we are unable to yet come around, because it imposes very, very serious questions on the logistics of providing healthcare for all workers. Right now, the discourse is very much around safety and services. So if you think about a construction site, for example, or a garment factory, the first thing that the government will talk about in terms of restrictions is the safety. That's where the permissions are, and the services. However, when you talk about occupational health alone, you fail to understand other forms of health needs of workers, whether it's reproductive need, or it's tuberculosis, or any other kind of health requirements that migrants experience. The same with child health. It's rarely ever considered to be a part of the package of services that we consider for migrant workers, and that is absolutely critical that we address child health. One of our research projects has shown that undernutrition is particularly high among migrant children. Currently, the conversations around universal coverage tends to focus on portability, but we want to constantly point out that portability is insufficient. We need to talk about universal in the true sense of the term. That means whether the family is left behind or the family is traveling, all kinds of arrangements need to be available, because there are various ways in which people undertake migration. This also needs to feature in our budgetary allocations. Very interesting. Anuj, I'll just take a minute more. I'm sorry. During our conversations with the Labor Department, for example, the conversation is always about who's going to pay for migrants' health. You should ask that state, because that's where they come from. So there is this state-centered fight, which we need to address at some point. And especially for things like maternal health, TB control, we need to think about solutions both at the source and destination region. And of course, the focus on data for migration. Right now, migration and health is not studied together. We have very few few micro studies that are done at different sites, but we need a much bigger data source to be able to tell us what the real situation is. I have one more slide, but I'll probably come back to that in the Q&A. Thanks.
Thanks a lot, Divya. That was, again, an excellent overview, specifically in specific regards to the internal migrants in the Indian context. And I think there are a number of issues that we can pick up, including the point that about insurance that you were referring to, and the portability of some of these provisions, documentation requirements. And I think goes back to the first point that Rumi was also making with regards to with regards to the very precarious and mobile nature and transient nature of this population that makes provisions in particularly more challenging. But we'll come back to some of these issues. And now the session moves on to the policy focus and what lessons from policies in specific countries we can learn from. And the two examples in particular that we're going to draw on, one is the context in Pakistan, but also a successful or an innovative approach to bringing migration health together in Philippines. With that, I want to invite the next speaker, Dr. Shabnam Sarfaraz, and a delight to be welcoming her despite the difficult circumstances that she's and health experiences that she's had. Shabnam is member of Planning Commission, member of Planning Development and Special Initiatives Department in the Government of Pakistan. She's a senior strategic communication and policy management professional with decades of experience, and also visiting scientist at Harvard Institute. She is currently leading the Socio-Economic response planning to mitigate the fallout effects of COVID-19 in Pakistan. And in that capacity will be sharing with us the insights from that experiences and the extent to which it addresses migrants' health needs. Over to Shabnam.
Thank you, Anuj. I'll pick from where Rumi left her presentation. There was a policy and systems gap that overlooked the needs of migrants and similar marginalized groups in Pakistan. We had taken a stock of it in our previous policy renditions. We were aware of the evidence gaps as well as the system challenges in addressing the issues, particularly due to paucity of relevant data. The populist opinion was that this is a non-agenda. Rumi had highlighted the status of systems and policies up to March 2020, and this was the time around which Pakistan saw its first COVID-19 case. We had started putting some systems into place to make them sensitive to the needs of the migrants. As the disaster struck the entire globe, we somehow looked at this as an opportunity to put our house in order. I would take a moment here to step back and share the overall governance structure in Pakistan for some of the audience who are unfamiliar with it. Pakistan has a devolved governance and administrative structure with a national government and provincial government for its 6 provinces, and health is one of the many devolved subjects, making the entire process of policy making even more complex and complicated, particularly in emergency situations. As you've already seen, there are huge disparities in demographic challenges and health systems across the provinces, which makes the role of the national government and the federal ministry, where I sit, even more tricky. I work at the Planning Commission, which is the apex planning and policy making body, and it has the unique convening power. And I'm heading the portfolios for health, population, youth, and manpower development, education, and SDGs, and also orchestrating interministerial and interprovincial coordination for these areas. And this was particularly helpful being at the Planning Commission at the time of COVID-19. Before COVID, we were already working to mainstream migrants' needs in our systems. A scoping study was underway to establish the migrant population's identities in Pakistan. This was challenging because definitions and connotations vary from geography to geography. Simultaneously, we were also organizing and designing a national civil registration and vital statistics systems with government and UN partners. The pilot model of which was already approved, but the launch was delayed because of the immediate shift in response and action focus due to COVID-19. Thirdly, we were already working with relevant partners to identify challenges faced by migrant populations. We were trying to understand the barriers they face in accessing health services, distances, quality accessibility, any system biases that we have failed to look at them from our migrant blind eyes. One of the very first steps that the government took with the onset of COVID-19 was to establish focus structures for response. The government took a rapid stock of the systems that we had in place. A state-of-the-art National Command Center for polio was already operating in Islamabad, with extensive national and subnational reporting lines and responsibilities already established, and surveillance systems were in place with linkages to cross-sectoral ministries and departments. This center was immediately upgraded as the National Command and Operations Center, NCOC, which was headed by the Prime Minister for COVID, with linkages to Ministry of National Health Services, the National Disaster Management Authority, and such to take care of the health response. However, a bigger challenge was beyond stage of response, that of recovery and building resilience, because the existing health systems were very fragmented and very weak. And in certain districts, we were very challenged, having lack of appropriate critical care units and lab facilities. There was also the challenge of addressing the socio-economic fallout effects of the pandemic on the entire gradient of the population, the marginalized groups in the tails. This was the purpose of establishing the COVID-19 Secretariat that I'm leading. The Secretariat has been working very closely with the UN partners, the banks, academicians, national and international think tanks for the same. And it is serving as the conduit between the ministries, the departments, the donors, development agencies, for effectively coordinating their support for COVID-19 national response, because everybody started gearing up, but we wanted our activities to supplement one another rather than duplicate. This central response played the pivotal role in ensuring that migrant health policies become a part of the COVID-19 national response, because we were very conscious of integrating it into the plans that we were building up. The COVID-19 Secretariat immediately engaged the UN partners to work on the socio-economic impact analysis of COVID-19 on vulnerable populations. This analysis was very helpful, and it was feeding into the National Action Plan for COVID-19, where we wanted to ensure that the poorest of the poor, the most marginalized, and that no one is actually missed from the response design, as they are the ones to be, they were the ones to be affected most by this pandemic. A participatory review approach was adopted for this analysis to ensure that this entire process remains inclusive and all concerns get addressed. This was indeed instrumental in developing a singular understanding, that of prioritizing the marginalized groups across the entire response spectrum of COVID-19. The report that we did on socioeconomic impact assessment was supplemented by development of a multidimensional vulnerability index. This had focus on needs of migrant population and other vulnerable groups. There were a lot of debates around limited resources and going where we got most out of each dollar that we were investing. But then we took a step back, went onto the balcony to take a holistic review, and also tried to understand that this is not just about making an investment. This was basic human decency, what we all here call the right-based approach. We immediately, at the Planning Commission, repurposed the financing from the existing projects, programs, and schemes, which was already approved prior to the COVID-19. Alongside, we approved emergency response from donors and development partners with expedited processing at our end. Around $450 million was earmarked for disaster response and design of resilient systems from within our own government's funding. The development partners and donors pledged loans, grant, and budgetary support. We also worked with ministries to repurpose the funding from their existing programs towards COVID-19 response. In March, when our numbers were still in double digits, Around $588 million was approved for emergency response to COVID-19, supported largely by the World Bank and the Asian Development Bank. And this was to mitigate, in response to COVID, and also to mitigate the socio-economic disruption which was associated with it. We were able to plot migrants' specific needs across the SDG framework and build it into the national COVID-19 response, their health, access to education, livelihood challenges, and other related factors which were affected. This included a socio-economic relief package for the migrant population, telemedicine and teleeducation opportunities, and support of partners in delivering the same, data monitoring, surveillance in campsites. There is order in chaos. To design framework at output, outcome, and impact levels, evidence is absolutely critical. Data has the answers, and because we are resource constrained, we cannot afford not to research. No matter how big the urgency is, we need to determine the scale of the problem and design accordingly, and also not to duplicate. We need to look at the whole pie and not the chunks, which is my biggest challenge while I'm sitting at the Planning Commission. Operating in silos often results in sidelining and exclusion of many priority agendas. Only by looking at the whole, we can address the matter. Often I'm asked that how much money is available so that we plan accordingly. And I always say, make your plan, and we will see that how much of the funding that is right now available can contribute to that overall pie rather than doing it by chunks. There is always a window open. We need to actively look for policy opportunities. COVID was one, I feel, and worked in favor of migrant health. There are many such opportunities all around us as long as we know where to look for them. Sing along song. This is not a one or two player game. Everyone has to be on board and everyone has to agree to make the change. This is a system-wide change and needs an adapted lens. And as I said, with a devolved subject, health being a devolved subject, it was quite challenging. Again, education for us is again a devolved subject. So getting everybody to the agreement is I think, the biggest challenge that we face. So you have to keep the dialogues open. And finally, it is a process. We cannot jump suddenly from migrant neutral to migrant transformative, skipping migrant blind, migrant sensitive, or migrant specific. It will take time for policy advocacy to work and for real change to be visible. But just because all your small efforts are not visible, I strongly feel it does not mean that they do not matter. They are like a magnetic field. The change will be visible, albeit in time, of course. Thank you so much. Thank you.
Thanks, Shabnam. That was really excellent insights into the policy process, both signaling how Pakistan has utilized that policy window created by a crisis of COVID, and is progressively putting in place that can place measures that can definitely go a long way in tackling migrant health. There are quite a few fascinating points that you were raising, which I would want to come back to after our next speaker's talk. Thank you for that. So with that, I'm really delighted and pleased to invite Dr. Joel Bonaventura, who has been with the Department of Health in Philippines as the Chief Health Program Officer. He's a medical doctor and public health servant by training. And most fascinating thing about Joel is him spearheading and according leadership to the program that really brought together the migration and health policy. And he is going to share from that standpoint his experience of addressing migrants' health, from policymaking to program implementation, and facilitating to some degree the convergence of the two policy fields in Philippines. So over to Joel.
Thank you, Anuj. Let us wait a bit for the slides, but at this point, I'd like to say good evening from stormy Manila. We're gonna have a storm in a bit, and but I'm privileged to be speaking to you at this 6th Global Symposium on Health Systems Research to share the experience of the Philippines in terms of policy and program development for migrants' health. Can you all see my slide? Okay. All right. So I'm here to talk. I think it was Dr. Shabnum ended her presentation very well, and it fits to my as an introduction to my presentation, because she ended with a keynote that takeaway that it's a process. Policy and program development for migrants' health is a process, actually. And in my presentation, I'm gonna describe to you the process that basically took us in terms of doing the policy and the program development for the Philippines. To give you an insight about in an introduction basically to the Philippines. So I think many of you know about the Philippines being a country of migration. About 10% of our population is either working or living overseas. This is the data. Actually, it's quite an old data. It's 2013 data from the country migration report of the Philippines. We have just a few immigration here. 0.3 to 0.5% of the Philippine population are actually foreign nationals. However, one of the main distinguishing aspect of the Philippines is its institutionalized labor migration. In the report, it mentioned 1.8 million overseas Filipino workers who were deployed in 2012. We reached the 2 million mark in about 2015, 2016. And the latest data we have is 2.2 million Filipinos are actually overseas Filipino workers. And because of this, you have to also note that Philippines is looked as one of the countries wherein migration management is really specialized. And in terms of migration health governance, I'd like to give you an overview of the key agencies that are actually acting on the issue of migration health in the Philippines. So we have our Department of Foreign Affairs and the Department of Labor and Employment mainly. Our Department of Foreign Affairs have connections with our Foreign Service Post, which basically handles the assistance to nationals unit. And the Department of Labor Employment actually has specialized migration agencies such as the Philippine Overseas Employment Administration. So these are very specialized agencies which are mainly addressing overseas employment. We also have the Overseas Workers Welfare Administration, or the OWA, as well as the National Reintegration Center for Overseas Filipino Workers when they come back basically to the country. So the migration governance in Philippines is such that it actually encompasses the whole migration cycle. Another, and most notably, another specialized migration agency is the Commission on Filipinos Overseas. It is actually under the Office of the President, which deals mainly with other overseas Filipinos, not necessarily the workers. So also a key player in migration health governance in Philippines is the Department of Social Welfare and Development, which also have representation in the foreign service posts with social welfare attaché. So in this slide, this will sum up about 3 years of our experience in basically developing the Philippines policy on migrant health. So way back 2013, there was a signing of a memorandum of agreement between the Department of Health and the International Organization for Migration. And there was an initial funding that was also devoted for us to be able to conduct a stakeholder analysis on migration and health governance in the country. So basically, you see the pictures of various countless meetings wherein we were basically consulting. Since migration is quite advanced in the country, so many stakeholders from NGOs, civil society, academic partners, academic institutions, and other private sector like recruitment agencies. So all their study were aimed at noting the stakeholders involved in the governance of migration and health in the country. The results of that study was actually presented in 2014 via the what we have the first national conference on migrant health. Incidentally, we will be having our virtual fourth national conference on migrant health next week, which is basically a week from now, which is the 1 month prior to the celebration of the International Migrants Day. In December 2014, the Department of Health was also involved in an interagency celebration of the Month of Overseas Filipinos, wherein every December we celebrate the achievements of overseas Filipinos in the country. And in 2015, there was a lot. This prompted up after the processes and the consultations that were held into policy development and basically organizing of a Philippine migrant health network. So we kept the discussions going and basically had all the issues and concerns elevated to the proper agencies. That all the work that we did in 2015 culminated in March 2016, when finally the national policy on the health of migrants and overseas Filipinos was issued, which is in this slide, which is basically a landmark policy wherein it basically sets the overall policy directions and the national framework for addressing the health of migrants and overseas Filipinos. This is quite a landmark thing because when you consider universal health coverage, we believe that we are not considering only universal health coverage for the 90% of Filipinos who are in the Philippines, but actually even this universal health coverage should not leave behind the 10% of the Filipino population. So this order basically established the Philippine Migrant Health Program at the Department of Health and created the Migrant Health Unit, which I currently head, and at the Bureau of International Health Cooperation. So it's a unit, it's a small unit which I'm heading, and basically it is reporting to the Health Policy and Systems Development Team, which reports to the Secretary of Health. And it interacts with the Philippine Migrant Health Network, serving as its secretariat, and an intra-agency task force on migrant health. So the next few slides I'll be showing you is just to show you basically, I cannot possibly discuss this in the next in a short span of time, but basically just telling you about how the role of the Migrant Health Unit has evolved since its establishment. We only had we identified about 8 areas, program areas, what we call, but then now it's about 22 plus. That's outside of the COVID work as well. So now we divide them into basically ones that are directly handled by the unit, and the next slide, which will be the ones that are basically coordinated with the other units at the Department of Health. So you can see really the breadth of the work of the unit, and as Shabnum has mentioned, it's really a process. So we identify this as we went along. We also initially focused on our overseas Filipino workers, but now we're also, as you might note in number 8, we're also in the Migrant Health Unit is also involved in terms of in the Interagency Standing Committee on the protection of refugees, asylum seekers, and stateless persons. So there's a lot of this work, as well as leading in regional and international discourses on migrant health. Philippines is leading the ASEAN in terms of development and an ASEAN guideline and an ASEAN framework on the documented and on the health coverage of documented migrants, and hopefully spearheading the establishment of an international office for health operations. Other things that are coordinated with various offices, we see this, the COVID, like for example, the COVID, we're coordinating this with our Bureau of Quarantine and the Epidemiology Bureau in terms of international health regulations. And you see a lot of various issues from HIV and AIDS, TB, malaria, vaccination for Hajj pilgrims, victims of referral of victims of trafficking, abuse, and violence against women, migration of health workers, because Philippines is the major source of health workers, especially of nurses, to the world. We also have the insurance system, the Overseas Filipinos program. So a lot of these things are being coordinated with various offices in the DOH, basically mainstreaming migration in the health sector. And I know I don't have much time,
Joel, can
but
you
I'd
wrap up?
like,
Yes.
yeah, I'd like to just tell you that the unit basically also was primordial in the response, wherein we did surveillance of cases among overseas Filipinos and those who are returning from overseas. And just finally, the insights, I think I can summarize into four. First one is about really mapping out the various stakeholders. This has to be done prior to any policy or program development. I think it's helpful to have establish a focal office for migration and health concerns, as this basically spans out the role of the unit, and strengthening of the country's migrant health programs by migrants across migration cycles. So it should be a multi-sectoral, multi-stakeholder, whole of government, whole of society approach in order to tackle migration health because of the numerous stakeholders involved. So I think with that, I can end my presentation. Thank you.
Thanks, Joel. Again, a very enlightening talk laying out the process followed in Philippines and key lessons learned. I am aware that we have very little time for question and answers, but maybe the three that we have, if you can be very succinct in your response. So to Divya, if you could elaborate on some methodologies or even approaches that have been successful in looking at migrant health within a social determinant frame, so beyond the occupational health context, if that's something that you can respond to.
I think we need to do a lot more fieldwork and field research at work sites where we think about health as beyond, just occupational work, various aspects, various types of health issues. And I think methodologically, I have actually a lot to say, but maybe we can connect through another channel. We definitely have to think out of the box on the kinds of methods we can use to do this kind of research, because there are inherent challenges, all kinds of barriers when you're trying to enter a work site. And so we have to be very, very creative and innovative in doing this kind of research. But I don't think.
Thanks, Divya. Can I also plug in the Migration Health South Asia Network? That was the link that was shared, is holding its methodological webinars starting 27th November. And just following what Divya is saying, there are methods that have been adopted which start with mapping not just work sites, but also resident sites of migrants, to be able to then go beyond migrants within workspaces, but also in residential spaces through hangout methodologies that we'll be talking about in the methodological webinar. Thanks, Divya. So over to Joel. And this is a question from Christy, who is saying that at Vigo, she's working with home-based workers in Philippines and wondering if you have any insight on people migrating within the Philippines for work, perhaps from rural to urban areas, and what barriers they might be facing in accessing healthcare, the internal migrant issue.
Yes, thank you, Christy, for the question. I think the internal migration basically in the Philippines is I would say threefold. Of course, we have the economic migrants who go to the urban areas in search of work. We also have the forced displacement because of the typhoons, the calamities, and also especially in the south, there are civil unrest and some war. So I think as with any other health system, the challenge is really having them assimilated in in the areas where they migrate to, and basically providing migrant sensitive services for them, and including them basically just like I think what Divya has mentioned and Rumi initially, how they are put in the local government's scope in terms of the population coverage.
Thanks, Joel. Shabnam, I'm going to pose this last question to you, and other speakers, please feel free to come on board here. So Claire's question is, her reflection is that one of the fundamental challenges with migration in UHC relates to the fact that so many of our national and international frameworks rely on the concept of state sovereignty and nation state as the unit of governance and implementation of policies. So where by definition, migrants are individuals who cross those borders. So to some extent, nation state focused approaches may never be able to fully accommodate their needs. Sorry to ask those most, a question which really demands a lot more time. Over to Shabnam.
Thanks, Anuj. This is such a, it's a beautiful question, but I feel that with COVID, we've all learned the lesson that everybody has to be included. Even if you leave, one city out, with our disease surveillance and all these plans that we are putting into place, we are making sure that all the districts and even those which are remotest, they have to be included in all those plans. You cannot be resilient and responsive, particularly in the context of disease surveillance. And I think this provides an indirect opportunity to us to include migrants and to refine these definitions, and to revise them. Who made those definitions? We made them. And this is the time that people are most receptive. So I would encourage everyone who's out there, who's at the policy tables, that raise your voice, because this is the time that people will hear it. It's making sense much more than it ever did, So I'm very hopeful that, if we are all able to push some of these things, this is the time we must not lose on this opportunity.
Thanks, Shabnam. Really important reflection. And with that, I'm afraid we'll have to close this session. Really interesting questions. I do want to reiterate what Shabnam has just said. This is the time, and we know that making universal health coverage plans and our pathway to UHCs for all countries is not that straightforward. UHC itself is really it's an aspirational goal which can only be progressively realized. But in order to achieve that, incorporating migrants' needs is both part of that leaving no one behind agenda, making your health systems universal, but also a human rights issue from what we are seeing today. And COVID has opened up that space. There are a lot of countries which have now started mapping vulnerability. And going back to what Rumi has said in her presentation, that we really need to redefine these concepts and read to what extent has migrants research on migrants being done from a labor perspective versus a public health and a human rights perspective. To what extent have public health research on migrants' health needs been largely dictated by a very narrow focus on infectious disease and them as vectors of and transmitters of diseases. So I think we need to sort of revisit these questions and research, and as academics and researchers, we have a very important role to play here. There is a challenge of how we define terms, how we also expand the notions of vulnerability. And I think that across different country contexts, we are beginning to see an expansion of how we define vulnerability, how do we define marginality and precarity. And I think it is time that in order to ensure the universal health coverage goal and the SDG goals of leaving no one behind is achieved, that we take migrants' health seriously with an understanding that this is a highly heterogeneous group, variously defined, and that migration mobility in a globalized, interconnected world is a harsh reality that we need to contend with. So with that, thank you, a huge thanks and applause. I can do this virtual applause for our fantastic speakers for sharing both policy insights as well as the actual experiences and lived realities of migrants in very different country contexts. Thanks all to the audience for these questions, and please do join us on Migration Health South Asia Network and follow us on the webinars. Thank you.
Do we just leave?
No, so I'm waiting for the host to tell us how
The training.
how we stop this. Should we?
It was so hard to track
I know.
time.
It was, trust me, with four different window screens opened, it has been a challenge.
Okay, kindly mute video.
But what?
Okay, I guess we leave then. Yeah.
Okay, yeah. But thanks everyone. Thank you, speakers and audience.
Yeah, it was great. Yeah.
Yes, we'll
so our
connect.
scene was redeemed already.
Thank you.
All right, bye-bye.
Bye. Bye.